We are mapping the complex, meticulously choreographed timeline of how the entire respiratory apparatus, the lungs, the surrounding thorax, and the powerful respiratory diaphragm, is built from scratch. I mean, it is just a stunning high-stakes construction project when you think about it.
It really is. The level of coordination is almost hard to comprehend.
Our mission today is highly defined. You've shared incredibly detailed embryological sources, and we are going to use them to trace the exact phases necessary for the lungs to transition from tiny, rudimentary buds to fully operational organs capable of sustained independent gas exchange. And I want to stress for you, the listener, this isn't just a story about general fetal growth.
Well, not at all.
It's about architectural precision, non-negotiable deadlines, and the biological timing required to survive the very first critical breath of life.
What's fascinating here is that we are tracing the development of a system that is fundamentally cooperative, yet structurally diverse. The overall developmental goal is, well, it's massive.
Right, it's not just one thing being built.
Exactly. We have to simultaneously create the sturdy network of conducting airways, the ultra-delicate respiratory terminals, establish a robust yet pressure-sensitive circulatory network, the pulmonary arteries and veins, and design the mechanisms for both gas exchange and continuous waste fluid management.
All at the same time.
All at the same time. It's a miracle of concurrent engineering. But the truly breathtaking insight, and this is a theme we'll keep coming back to, is the underlying mechanism driving all this complexity. We are tracing the constant necessary dialogue, what embryologists precisely call reciprocal induction.
Reciprocal induction, so a two-way conversation.
A continuous, intense conversation. Think of it as a constant back and forth between the architect, which is the surrounding mesenchyme tissue, and the builder, the epithelial cells lining the airways.
So the architect is saying, put a wall here, and the builder responds.
Precisely. The architect is constantly instructing the epithelial cells on how to branch, where to flatten, and what supporting structures to form, and the builder responds perfectly. The fate of the developing lung hinges entirely on this perfect conversation.
And it all starts incredibly early.
Unbelievably early. Our sources confirm this entire developmental process kicks off right around stage 12, which is roughly 30 days post-fertilization, and crucially, and this is so important for later on, the process continues actively long after birth.
Right, this isn't a project that's finished at 9 months.
Not even close.
Let's start right at the genesis then, establishing the initial architecture. It feels almost impossible that a structure as complex as the bronchial tree begins as just a little localized change on the floor of a primitive gut tube.
It speaks to the efficiency of the early embryo. It repurposes constantly. The very first visible sign of respiratory development is a simple, sharp outfolding known as the laryngotracheal ridge.
Well, ridge, so like a little wrinkle in the tissue.
Exactly. A little fold that appears in the floor of the primitive foregut endoderm. This is the material that will give rise to your entire lower respiratory system, trachea, lungs, everything, and it all happens around stage 12.
So this ridge is the starting material, and I assume it immediately starts to elongate, sort of defining the shape of the future windpipe.
That's right. That ridge quickly folds and deepens to form the laryngotracheal tube. And as this tube begins to grow, and the direction of growth is key here, it grows caudally.
Caudally, meaning downwards, toward the tail end of the embryo.
Exactly. And at its terminus, at the very end of this growing tube, it expands into a bulb-shaped sac we call the respiratory diverticulum.
Which is the lung bud, based on.
That's the common term for it, yes, the lung bud. By stage 13, this bud is clearly established. This primary caudal growth isn't passive. It's an active push that mechanically drives the developing lung bud into the anatomical space that will ultimately become the thorax.
So it's not just growing into an empty space, it's actively.
It's staking its claim on the chest cavity. It's carving out its territory.
That initial common origin in the foregut means that the most urgent, high-stakes architectural step has to be separation. You can't have food and air going down the same pipe.
That is the pivotal step. It's absolutely mission critical. Failure here results in chaos. For a short time, the trachea and esophagus are just one shared foregut-derived channel. The body has to actively and rapidly partition this channel, effectively zipping it up from the bottom.
Zipping it up. How does the body manage that critical zipping process in those first few weeks? It seems so prone to error.
It happens through the coordinated development and fusion of internal walls. Longitudinal ridges start to form along the lateral walls of the foregut tube.
So on the sides, growing inwards.
Exactly. These ridges grow inward toward the midline, like curtains closing, and eventually fuse completely to form the tracheoesophageal septum, or the TE septum for short,
And this happens fast.
with stunning speed. It's typically complete by stage 13 or stage 14. Once fused, this septum successfully separates the trachea ventrally, where the air goes, from the esophagus dorsally, where the food goes.
And if we think about the final adult anatomy, the larynx is the only remaining point of communication between the respiratory system and the pharynx. That means the separation has to be precise, leaving that entry point perfectly intact.
Precisely. The larynx is established as a sole gatekeeper, allowing communication for swallowing and phonation while keeping the lower airways sealed from the gut contents. Which, of course, brings us directly to a critical clinical insight we must draw from these sources.
The failure of that process.
The failure of that septation process. If it fails even partially, it results in a tracheoesophageal fistula, TEF,
A fistula being an abnormal connection.
an abnormal open connection between the trachea and the esophagus.
We really must emphasize the severity of this. If a baby is born with a teeth, what does that mean functionally, right out of the gate?
Functionally, it is devastating. In the most common types of teeth, the upper esophagus ends in a blind pouch. This is called esophageal atresia, and the lower esophagus connects directly to the trachea via the fistula.
Okay, so let's break that down. The baby tries to swallow.
Right. A newborn baby attempting to swallow saliva or milk will have that fluid accumulate in the upper pouch because it has nowhere to go. This leads to choking and aspiration of that fluid directly into the lungs from above.
And from below.
Worse, air can pass from the trachea into the stomach, causing the stomach to distend painfully, and stomach acid can reflux directly up into the lungs through that same fistula. The source material emphasizes that this failure of septation is not just an anatomical error, it's a failure to establish the fundamental protective barrier needed for life.
So once that trunk, the trachea, is successfully partitioned and established, the lungs then start the immense task of building the actual branching architecture, the bronchial tree.
Yes, and the architecture that follows adheres to a very specific and I think beautiful geometric model. Primary bronchial buds emerge from the caudal end of the trachea right after the separation, around stage 13. From there, the entire structure develops through what is known as dichotomous branching.
Dichotomous branching. It sounds technical, but if we break it down, it's a simple rule that generates exponential complexity. Can you give us an analogy for the listener?
Of course. Think of it like a specific type of fractal growth pattern, or maybe a simple river delta forming in sand. At the end of every existing branch, the growth tip doesn't just sprout 1 or 3 new branches, it always divides into exactly 2 new branches.
Always two.
Always 2. It's a precise geometric rule that is reiterated countless times, building complexity incredibly quickly. You go from 1 branch to 2 to 4 to 8, 16, and so on. And this isn't random growth. As we discussed, this entire branching morphology is tightly controlled by that reciprocal induction. The mesenchymal cells are telling the epithelial cells, branch here, but ensure you also leave space for a piece of cartilage and a blood vessel.
The architect and the builder working in concert.
It's this constant communication that ensures that the necessary supporting structures, the cartilage rings for stability, the smooth muscle layers for control, and the critical vasculature, are laid down precisely alongside the newly forming airways. It's simultaneous construction.
And what's truly remarkable is how early the distinct gross anatomy of the adult lung is decided. We know the right lung has 3 lobes and the left has 2 to make room for the heart. When is that fundamental asymmetry established?
Immediately. It's established as those primary buds divide into the secondary bronchi. By the end of stage 14, just days after the initial bud appears, the structural architecture is already set.
That early.
That early. The right side develops 3 secondary bronchi, which are the blueprints for the 3 future lobes, while the left side only forms 2 secondary bronchi, leading to its 2 lobes. This early asymmetrical branching pattern is a fundamental outcome of the initial positional cues and dictates the final shape and size of the 2 lungs for a lifetime.
That covers the initial blueprint and the building of the trunk and primary branches. Now we transition from the architecture phase to the refinement phase, the famous 4 chronological stages that define the lung's functional readiness. These phases are the countdown timer dictating whether or not the baby stands a chance at independent survival.
And these stages are absolutely essential clinical markers. They track the lung's transformation from looking like a useless network of solid tubes to becoming a highly efficient, spongy gas exchange surface.
Okay, phase 1. Let's start with the longest phase, the pseudoglandular stage. It spans from week 6 all the way to week 17. The name itself suggests a disguise. It looks like a gland, but it is not.
That's absolutely correct. It's named the pseudoglandular stage because histologically, when you look at the developing lung tissue under a microscope, it is dense and branched. It looks precisely like an exocrine gland, such as a salivary gland.
So it looks solid.
It looks solid, a dense network of ducts and cords. The primary monumental achievement of this phase is structural completeness of one part of the system. All the major elements of the conducting airways are established.
The conducting airways, so that means the bronchi down to the terminal bronchioles.
I love it.
So if we use the tree analogy, the trunk, the massive branches, and all the smaller twigs are built. But the essential leaves that actually perform the work, the gas exchange, are completely absent.
Perfectly put. They're completely absent.
What is the functional limitation here, and why is survival absolutely impossible at this stage?
The limitation is absolute and it is non-negotiable. Gas exchange is entirely impossible. The airways just end in blind sacs lined by thick cuboidal cells. There are no respiratory bronchioles or alveoli yet. And crucially, the vascular structures, the capillaries, are still relatively distant from the airway epithelium.
So there's no way to get blood close enough to the air.
No possibility of establishing a viable blood-gas barrier. This is purely a construction period, a scaffolding period, not an operational period.
But even during this stage, the body is setting up the pieces for the future, particularly regarding that key molecule we'll talk so much about, surfactant.
Yes, the cellular specialization begins here. It's really foresight. The first appearance of the critical type 2 pneumocytes occurs around post-fertilization week 12.
And these are the surfactant factories.
These are the cells responsible for producing surfactant, which will reduce surface tension and prevent the lungs from collapsing. They appear first in the more proximal or upper airways. However, and it's vital to clarify this point.
They're there, but they're not working yet.
Exactly. While they are present, they are not yet fully structurally mature, and they are not actively synthesizing or storing surfactant yet. They are differentiating, finding their place, and essentially waiting for the signal to begin manufacturing.
And what role is the mesenchyme, the architect tissue, playing in this extensive 11-week phase? It must be incredibly busy.
Incredibly busy. This is the stage where it solidifies into the future pulmonary parenchyma. It's differentiating intensely, which means it's turning into all the necessary supportive structures. Like the foundational connective tissue framework that gives the lung its shape and strength, the layers of smooth muscle that will allow airway control, like bronchoconstriction, and most importantly, it's organizing the complex vascular structures that will eventually need to press right up against the air sacs for gas exchange.
So it's building the scaffolding and installing the circulatory plumbing at the same time.
At the exact same time. It's a masterclass in coordination.
Which brings us to phase 2, the canalicular stage. This is from week 17 to week 27.
The canalicular stage, yes. This is often called the viability window because it marks the critical point where survival might become possible, usually right around 24 weeks gestation.
And the name canalicular, that refers to canals or widening channels?
Exactly. That's the key process.
How does the structure fundamentally transform to leap from zero viability to potential viability within this 10-week window? What's the key architectural shift?
The transformation is twofold, and it's all about maximizing space and proximity. First, the key process is that canalicular development. The airways themselves significantly widen. They go from being narrow tubes to much wider canals. Second, the terminal bronchioles that were established in phase 1 begin dividing into the first respiratory bronchioles.
And these are the first structures capable of gas exchange.
They are the transitional zones between conducting air and exchanging gas, the first hint of functionality.
And this widening must bring the blood vessels much, much closer to the air spaces. That's the real trick, isn't it?
Precisely. This structural change is entirely dependent on the mesenchyme. It begins to thin out and regress substantially. As that interstitial space shrinks, the capillaries start to sprout and appear immediately adjacent to the newly widened respiratory structures.
The wall is thinning.
The wall separating air and blood starts its critical journey toward becoming almost unimaginably thin.
This thinning must trigger the final transformation of the lining cells themselves, right? Moving away from thick, protective walls toward thin, efficient barriers.
That is the defining cellular shift of this stage. The thick cuboidal epithelium that lined the airways in the pseudoglandular stage starts to flatten dramatically. This is due to signals from the mesenchyme, from the stretch, from the proximity to the capillaries.
And these flattened cells become.
They become the crucial type I pneumocytes. These are the thin, pavement-like cells, making up over 90% of the alveolar surface area in an adult. They are specifically optimized for one thing: rapid gas diffusion. They are the actual exchange medium.
So the combination of thinning mesenchyme, the newly adjacent capillaries, and the flattened type I cells creates the primitive blood-gas barrier. But how primitive are we talking at 24 weeks? Can it really work?
By approximately 24 weeks, the sources indicate that some capillaries are in such intimate contact with the type I cells that a primitive but functional blood-gas barrier is established. It's functional, but it's still relatively thick compared to what it will become, and the capillary coverage is still minimal. It's patchy.
I see.
This is why survival is technically possible at this point, but requires maximum life support, maximum medical intervention. It's a testament to the fact that the basic machinery for gas exchange is now present, even if it's operating far, far below adult efficiency. It is the absolute minimal prerequisite for life.
Which moves us into the third trimester and the saccular phase. This is from about 28 weeks until term. The focus shifts from just building primitive barriers to refining the air sacs and optimizing efficiency.
Right. Structurally, this stage is defined by the terminal air spaces ballooning out into definite thin-walled sacs, which we call saccules.
So not true alveoli yet, but they're precursors.
Exactly. They are the final air containers that will eventually be subdivided into the mature alveoli. Think of them as large, open-plan rooms before the cubicles are installed.
The push for efficiency must be unrelenting here, because we are preparing for the ultimate deadline birth.
Absolutely. The refinement process happens on two critical fronts. First, the mesenchyme continues its intensive regression, shrinking the interstitial space even further, and simultaneously, the capillary network expands substantially, forming a much denser mesh around the saccules to maximize the surface area for exchange.
And this is where we find that microscopic, yet vital change you mentioned in the sources. The double to single capillary transition. This seems like a small detail, but it must represent a massive leap in efficiency.
This is a fantastic point, and it's often overlooked. In the earlier canalicular stage, the respiratory structures are generally surrounded by a relatively thick double capillary network. It's like having two small roads running on either side of a wall. During the saccular phase, there's a highly sophisticated process where these two capillary layers begin to merge or fuse. They consolidate into a much more efficient single capillary network that is tightly wrapped around the saccule wall.
Why is that fusion so crucial? What does it gain you?
It dramatically shortens the distance that oxygen and carbon dioxide have to diffuse. It turns a slightly thick two-lane road into a single high-speed highway for gas exchange. Our sources clarify that this critical fusion process, which establishes the ultimate efficiency of the blood-gas barrier, actually continues right up until 41 weeks post-fertilization. It is literally one of the last architectural pieces to fall into place.
Wow. And of course, this phase contains the final major hurdle for independent survival: the structural and functional maturation of surfactant production, the grand opening of the factory.
Exactly. The type 2 pneumocytes become completely structurally mature. We can literally see this under a microscope by the sudden appearance and massive accumulation of lamellar bodies within the cells.
Can you explain what lamellar bodies are for our listeners?
Of course. Lamellar bodies are essentially high-density storage units. They are specialized organelles, like little packets where surfactant is packaged and stored, ready for immediate release at the first breath. Achieving adequate, stored, and releasable surfactant production is the last major prerequisite for viability leading up to term. It dramatically lowers the risk of that life-threatening respiratory distress syndrome.
Which brings us to the final stage, the alveolar phase. This starts late in gestation, around 36 weeks, but we must stress this is truly a process that extends years into childhood.
That's so critical to understand. Birth is simply a change in the environment, not the completion of the project.
This stage marks the true formation of the mature, complex alveoli. The key mechanism driving this massive increase in surface area is known as secondary septation. So if the saccules are the big primitive air balloons, secondary septation is the process of putting internal walls into those balloons to create many smaller, interconnected chambers.
That's a perfect way to visualize it. The walls of the existing saccules start projecting thin folds, the septa, into the lumen, into the open airspace. Think of a simple, large room suddenly being divided by internal walls into 10 smaller, interconnected offices.
And each new wall adds more surface area for gas exchange.
Exactly. This subdivision drastically increases the total gas exchange area without needing to increase the overall lung volume much at all. It's about maximizing efficiency in a confined space. And this is where the timeline truly stretches out. While it starts late in utero, the majority of alveolar development, the true complex architecture of the adult lung, occurs after birth.
The numbers are incredible.
The data is staggering. The number of alveoli rapidly increases about tenfold by the time a child reaches age 3, and the growth in complexity and volume continues until age 8 or, in some individuals, even later, possibly into adolescence.
It fundamentally changes how we view lung vulnerability. It's not just a 9-month window of development. It's an entire childhood process. And beyond the air sacs themselves, the supporting tissue is also finishing its maturation during these postnatal years.
Absolutely. The thick, elastic tissue that lines the alveolar walls in the early fetal stages matures and thins out postnatally. It becomes much more flexible and resilient.
Which is important for breathing out, for recoil.
It is essential for the elastic recoil, the mechanism that allows the lungs to snap back naturally after inspiration. It's critical for the overall mechanical compliance required for efficient adult respiration. It just underlines the fact that lung function and form are dynamic and sensitive well into the grade school years. So now we must turn our attention to the supporting cast. The lungs construction is only half the effort. For the lungs to actually inflate and function efficiently, they require a perfectly engineered cage, the thorax, and a powerful, reliable engine, the diaphragm. And what's architecturally amazing is that these supporting structures arise from entirely different embryological origins than the lung tissue itself, and yet they must meet and interface flawlessly.
Okay, let's start with the space itself. We established that the lung buds push caudally into the body cavity. What is that initial undifferentiated space, and how does it get transformed into the sealed, isolated pleural cavity that's so necessary to hold negative pressure?
The initial common space the developing lung buds project into is called the pericardioperitoneal canals. This happens way back around stage 12.
Pericardioperitoneal, so heart-abdomen.
It's a primitive communication route connecting the heart area, the primitive abdominal area, and the future chest area. The problem is you can't have your heart beating in the same compartment as your lungs or your gut pressing on your lungs. It would be chaos.
So those canals have to be partitioned meticulously to ensure the lungs, the heart, and the abdomen all occupy separate pressure-sealed spaces.
Partitioning requires 2 distinct growing sets of membranes. First, the pleuropericardial membranes grow medially to separate the heart cavity, the pericardial cavity, from the lung cavity, the pleural cavity.
Heart from lungs.
And second, and arguably more critical for breathing, the pleuroperitoneal membranes grow to separate the lungs from the abdominal cavity, the peritoneal cavity.
And this is where the septum transversum comes in. The sources describe it as the foundational piece of the floor.
Exactly. The septum transversum, or ST, is a thick shelf of mesenchyme. It forms the large central tendon in the major part of the diaphragm, but embryologically it starts as a partial wall. It provides a massive floor for the developing thorax, and it's the anchor point that the pleuroperitoneal membranes must successfully fuse into.
So they grow and fuse to the septum transversum, sealing the deal.
Sealing the cavity. The end goal of the fusion of these membranes is to seal off the space. This is a vital mechanical requirement. The fusion ensures the lungs occupy their own sealed pleural cavities, which is necessary to prevent the transmission of abdominal pressure and, more importantly, to allow the maintenance of the necessary negative pressure differential that drives quiet breathing.
Okay, so that's the space. Now for the engine. The diaphragm is an embryological puzzle. It's the primary engine of respiration, but it is assembled from 4 completely different sources. It's a true composite structure.
It is a stunning example of complex migration and fusion originating around stage 17. The sources clearly detail the 4 components that contribute to this dome-shaped muscle.
I'll walk through them.
First, the septum transversum, which we just mentioned. It forms the large non-muscular central tendon. Second, the pleuroperitoneal membranes, which form the posterior margins. Third, the dorsal mesentery of the esophagus, which contributes tissue that forms the muscular crura, the legs of the diaphragm that attach to the spine.
And the fourth.
Finally, the muscular components derive from the lateral and ventral body walls. All 4 have to come together and fuse perfectly.
This composite origin explains one of the greatest anatomical curiosities: the extremely long, circuitous path of the phrenic nerve. It powers the diaphragm, but it originates way up in the neck. Why does the nerve have to travel so far?
This is a classic instance where embryological descent dictates adult anatomy. The muscle tissue of the diaphragm doesn't originate locally in the chest. It arises from specialized precursor cells, the myoblasts, that migrate all the way from the cervical somite.
Cervical, as in the neck.
Yes, specifically the C3, C4, and C5 segments located high up in the neck region around stage 13.
So if we imagine the body as a pugget, the nerve attaches high up, but the structure itself is pulled way down.
That's the perfect analogy. The nerve attaches in the neck, but then the entire composite diaphragm structure undergoes a significant caudal descent, a downward pull during embryogenesis. It shifts from the neck region all the way down to its final position, a process that continues for several weeks.
And the nerve just gets stretched out along with it.
The phrenic nerve is attached to the muscle cells that originated in C3, C4, and C5, so the nerve must maintain that long, circuitous route all the way down through the chest to innervate the diaphragm, even after the descent is complete. It's the physical evidence of its neck origin.
And if that pluriperitoneal membrane doesn't successfully fuse with the septum transversum, we get that devastating clinical condition we mentioned earlier, the congenital diaphragmatic hernia.
Exactly. Congenital diaphragmatic hernia, CDH, is a failure of that seal. If the pluriperitoneal membranes don't close the posterior lateral gap, abdominal organs like the stomach, intestine, or liver can herniate up into the thoracic cavity.
And this isn't just an abdominal problem, it's a lung problem.
It's primarily a lung problem. It places severe physical stress on the developing lungs, leading directly to the single most critical complication, pulmonary hypoplasia. The lungs cannot expand and grow properly when they are being compressed by a liver. The architectural failure immediately causes a functional crisis.
Finally, we need the cage itself, the supporting architecture of the thorax. Where do the bony elements like the ribs and vertebrae come from?
The vertebrae and the ribs are derived from the foundational building blocks of the early embryo, the somites, which are themselves derived from the paraxial mesoderm. The ribs begin simply as costal processes, small cartilage-like extensions, and then they bend ventrally, growing forward to meet the mesenchyme of the lateral body wall. This process starts early, around 14.5 days post-fertilization.
The sternum, the breastbone, seems structurally necessary to complete the cage, but it forms surprisingly late in the process.
The sternum is one of the final pieces of the skeleton to form in this region. It forms around stage 21 or week 7, long after the initial branching of the airways has begun.
And how does it form?
It originates from 2 parallel mesenchymal sternal bars that develop independently in the front of the body. These bars then begin to fuse in the midline, and this fusion progresses in a caudal direction. From the top, the manubrium, downward toward the bottom, the xiphoid process.
So errors in that fusion process or the growth rate of the cartilage can lead to lifelong structural anomalies of the chest wall.
Precisely. Anomalies like pectus excavatum, the common sunken chest, or pectus carinatum, the protruding pigeon chest, are directly related to abnormal costal cartilage development and the failure of the precise timing and pattern of fusion of those mesenchymal sternal bars. The structural integrity of the cage must be perfect, not only to protect the lungs, but to facilitate the proper mechanics of breathing.
It is so easy to mistakenly think of the fetal lungs as passive, dormant organs since they aren't exchanging air. But they are far from it. They're operating a highly specialized dynamic system, actively involved in managing circulation, regulating internal fluid, and promoting their own structural growth. They're running the self-diagnostic checks before the final launch.
That's a great way to put it. They're running a complex metabolic laboratory, preparing both the hardware, which is the structure, and the software, the physiological readiness, for a massive system reboot the moment the umbilical cord is cut.
Let's track the origin of the blood vessels. Given the complexity of the adult pulmonary system, where does this critical circulation network originate?
Well, the 2 major vascular systems, arteries and veins, have distinct embryological origins, and this is important. The pulmonary arteries, which carry deoxygenated blood from the right side of the heart to the lungs, develop from the specialized 6th pair of aortic arches.
And the veins.
The pulmonary veins, which will eventually carry oxygenated blood back to the left side of the heart, develop differently. They sprout from the caudal portion of the primary cardinal veins around stage 15, and they are later physically incorporated into the posterior wall of the left atrium.
During gestation, the fetal pulmonary system has a unique hemodynamic profile designed to actively shun blood away from the non-functional lungs. We need to explain why that happens and how.
That profile is defined by 2 key characteristics: high resistance and low flow. The fetal pulmonary vasculature is intentionally restrictive. It acts like a detour sign for blood.
Why so restrictive?
By about 20 weeks, smooth muscle develops around the pulmonary arteries, making the vessels highly muscularized and reactive. This intrinsic high resistance is absolutely crucial because it ensures most of the blood bypasses the non-functional lungs by flowing through the fetal shunts.
The ductus arteriosus and the foramen ovale.
Primarily those two, yes. The blood flows straight into the systemic circulation, which is managed by the placenta. The lungs only receive about 10 to 15% of the total cardiac output, just enough to keep the tissues alive and growing.
So the high resistance is what keeps the shunts open, ensuring that the blood flows down the path of least resistance, which is away from the lungs.
Exactly. The fetal body sees the lungs as a high-pressure zone and diverts the vast majority of blood around them. This temporary muscular thickening is a necessary developmental step that must be reversed instantly at birth.
We also must discuss the vital role of the lymphatics in drainage, especially considering how much fluid the fetal lung contains.
The lymphatics are the lung's sophisticated drainage network, and they are essential for maintaining dryness. Two separate lymphatic circulations develop, a pulmonary or deep one and a bronchial or superficial one.
And their job is to clear fluid.
They are crucial for moving interstitial fluid and proteins out of the lung tissue. Postnatally, their primary and most critical job is to drain the massive volume of fluid that fills the lung tissue and air spaces at birth, maintaining the lung's critically dry state. If the lymphatics are impaired, the lungs remain wet, which severely impedes gas exchange.
The fetus is surrounded by amniotic fluid, but the lungs themselves are filled with a completely different specialized substance, fetal lung fluid. Tell us about this fluid. It's not just inhaled amniotic fluid.
No, absolutely not. The fetal lung is filled not by passive accumulation, but by fluid that is actively secreted by the pulmonary epithelium. Near term, this can be at rates exceeding 5 milliliters per kilogram per hour.
And it's chemically different.
Yes, this fluid is unique. It has a different ionic composition than amniotic fluid. It's high in chloride and low in bicarbonate. But critically, this fluid maintains a necessary positive pressure within the airways.
Why is that positive pressure so important? Is it just keeping the tubes open?
It's far more than that. The positive pressure is absolutely essential for physically promoting normal lung growth and expansion. It acts like a scaffolding from the inside. It provides a constant mechanical resistance that stimulates the developing lung cells and tissues to proliferate and differentiate properly. It's a continuous internal mechanical signal for growth factors.
And the mechanical action of breathing movements, even though the fetus is immersed in liquid, also serves a structural function for growth.
We call these fetal breathing movements, or FBMs. They are continuous rhythmic movements involving the thoracic wall and diaphragm muscles. Initially, they are irregular, but they become organized and rhythmic later, starting around stage 20.
And they aren't for getting oxygen.
No, not at all. FBMs are neuroregulator-driven, they are influenced by the fetal sleep-wake cycle, and they are vital for providing continuous mechanical stimulation and stretch to the developing tissue.
So the lungs are essentially practicing, but more importantly, they are ensuring their own architecture is strong by stretching the tissues.
Exactly. The mechanical stretch provided by FBMs is a powerful stimulus for cell differentiation, matrix deposition, and ultimately for branching and alveolarization. This is a point of crucial clinical significance.
Right.
If FBMs are reduced or absent, say, due to severe oligohydramnios, which is low amniotic fluid, that limits chest wall movement, or because a large diaphragmatic hernia is physically blocking movement, the resulting lack of mechanical stretch contributes profoundly to pulmonary hypoplasia, the severe underdevelopment of the lungs.
The fetus needs that constant internal pressure and external workout to grow correctly.
It absolutely does.
Let's return to surfactant. It's the lipoprotein that carries the weight of the entire respiratory transition on its shoulders.
Surfactant is synthesized, stored, and secreted by those type 2 pneumocytes we discussed earlier. Its chemical makeup is complex, but its functional role is monumental. It reduces the surface tension at the air-liquid interface within the developing air sacs.
Can you explain surface tension simply for us? Why is it such a profound threat to the newborn lung?
Of course. Imagine trying to blow up a very small, wet balloon that has the stickiness of honey inside it. Water molecules are highly attracted to each other, that's surface tension. If the alveoli are wet, that tension is high and acts like a powerful inward pulling force.
Trying to collapse the balloon.
Exactly. Without surfactant to neutralize that force, the tiny air sacs would instantly collapse entirely upon every single exhalation, a condition called atelectasis. Surfactant breaks the surface tension, making the air sacs easy to inflate and critically stable between breaths.
What controls the complex process of surfactant synthesis and storage in the weeks leading up to the final term deadline? It has to be timed perfectly.
Fetal lung maturation is heavily influenced by external endocrine factors, essentially hormones telling the type 2 cells to prepare for the grand opening. Our sources specifically point to corticosteroids, such as cortisol, as the key hormones.
Cortisol, the stress hormone.
Yes, and these hormones act as powerful accelerators. They send a signal to the cells to ramp up the synthesis and storage of all the necessary components of surfactant, the proteins, the lipids, everything.
This understanding of hormonal control is why antenatal interventions are so effective when preterm birth is anticipated.
Absolutely. Because we know this pathway is hormonally driven, administering synthetic glucocorticoids to mothers facing preterm delivery is a proven and standard intervention. This strategy effectively speeds up the morphological maturation and surfactant production in the fetus. It's essentially a biological fast-forward button, buying critical time and dramatically improving the chances of survival should the baby be born during the canalicular or early saccular stages. It minimizes the likelihood of respiratory distress syndrome. So now we shift from the construction phases to the consequences. The staggering precision and the long developmental timeline required in these embryological weeks mean that even slight missteps or external interferences lead directly to major, often life-threatening health crises.
Let's start by delving deeper into the consequences of congenital diaphragmatic hernia, CDH. We know it's a failure of the pleuroperitoneal membranes to fuse, allowing abdominal organs into the chest. But how exactly does that lead to pulmonary hypoplasia? What's the mechanism?
It's a multi-layered problem, but physical compression is the primary issue. The herniated abdominal contents compress the developing lung tissue, literally preventing it from expanding. This inhibits the necessary mechanical stretch that drives branching and alveolarization.
The stretch from the fetal breathing movements we just talked about?
Exactly. So the hypoplastic lungs that result have a reduced number of bronchial branches and significantly reduced numbers of alveoli. They are small and structurally simplified.
And the physiological problem is not just size, it's vascular, right?
Correct. Hypoplastic lungs are plagued by severe and persistent pulmonary hypertension. Recall those thick, muscularized fetal pulmonary arteries. In CDH, the lungs are so underdeveloped and the structure is so altered that these arteries often fail to remodel after birth. They retain their high fetal resistance.
Which means blood still wants to bypass the lungs even after birth.
It contributes to severe pulmonary hypertension, which is often the factor that makes oxygenation impossible, even if the lung tissue itself could technically function.
And pulmonary hypoplasia itself can stem from multiple causes, not just a physical space constraint like CDH.
That's right. Pulmonary hypoplasia is defined generically as underdevelopment reduced size, weight, and structure of the lungs. We categorize the causes into two main groups. First, conditions reducing thoracic space, such as CDH or severe congenital heart defects that cause the heart to occupy too much room.
And the second group.
Second, and critically, conditions that reduce the necessary fluid volume and mechanical lung stretch. For example, prolonged rupture of membranes or severe oligohydramnios, which, as we said, is low amniotic fluid, often due to fetal renal agenesis, a failure of the kidneys to develop. This leads to a lack of the internal scaffolding pressure and a subsequent lack of FBM stretch. Without the constant internal and external stimulus, the lungs simply cannot achieve their necessary growth targets.
Okay, let's turn to preterm birth. This introduces developmental challenges because the baby arrives before the lungs have passed critical structural checkpoints, specifically that transition from the canalicular to the saccular phase.
This is the context for the most common and serious problem: respiratory distress syndrome, RDS. This syndrome primarily affects infants born during the canalicular or early saccular phase. This means the type 2 pneumocytes are immature and have not yet synthesized or released sufficient functional surfactant.
So what is the destructive pathology of RDS at the air sac level? What's happening with each breath?
The central pathology is the lack of adequate surfactant, which means the high surface tension inside those tiny air sacs dominates. This causes widespread, massive alveolar collapse atelectasis, with every single exhalation.
So the lungs just deflate completely.
Completely. This leads to severe inflammation, difficulty maintaining the necessary functional residual capacity, or FRC, and rapid lung exhaustion. The baby is essentially trying to reinflate collapsed sticky sacs with every single breath. It's an immense amount of work.
And survivors of severe RDS who require extensive medical support often face a second chronic condition, bronchopulmonary dysplasia or BPD.
Yes, BPD is a chronic lung disease, and its pathology is essentially an arrest or alteration of the normal alveolarization process. It typically affects infants who required prolonged life support, often because the necessary treatment mechanical ventilation, high concentrations of oxygen caused injury to the delicate, rapidly developing structures.
Injury like oxygen toxicity or high pressure damage, which is barotrauma.
Exactly. So the treatment, while life-saving, interferes with the lungs' final developmental program.
It derails the construction schedule.
Perfectly said. Instead of continuing the fine-tuning of secondary septation and capillary density, the process is derailed. The lungs of BPD survivors are characterized by simple, fewer, and larger alveoli, a permanent reduction in the complexity of the capillary network, and often pulmonary fibrosis and persistent airflow obstruction.
So the maturation that should have happened in those later phases is just stopped.
It's interrupted, resulting in a lifelong reduction in respiratory capacity.
We've established that the lung is built over a very long, vulnerable timeline. This means it is uniquely susceptible to external chemical and hormonal influences, starting even before birth.
The evidence is very clear that prenatal exposure to toxins or adverse maternal conditions can cause irreversible structural changes. Maternal factors like smoking, uncontrolled hypertension, or pre-existing diabetes can directly impact the fetal lung's developmental programming.
In what way?
Studies link this exposure to reduced airway branching efficiency during the pseudoglandular phase and severe abnormalities in the pulmonary vasculature, leading to later respiratory issues.
Given that the alveolar phase continues so actively well to middle childhood, is the postnatal environment just as critical for structural completion?
Absolutely. Since secondary septation continues actively up to age 8, the postnatal environment is a powerful determinant of future lung health. The sources note that chronic exposure to environmental toxins, especially air pollution, like traffic-related pollutants, is strongly linked to adversely impacting normal lung growth.
So it's not just irritating the lungs, it's actually stopping them from being built properly.
That's the key. This interference with the ongoing septation process physically limits the total number of alveoli a child develops. It reduces their maximum potential lung function later in life. The damage isn't just temporary irritation, it impacts the final architectural capacity of the adult lung.
We have covered the construction phases and the clinical risks. Now we arrive at the monumental instantaneous transition, what happens in the seconds, minutes, days, and years after the umbilical cord is severed, and the lungs must assume their full independent role.
It is the most dramatic physiological transition the human body ever makes. It's like throwing a switch from water power to air power in an instant.
The moment of birth is the moment gas exchange shifts entirely from the placental network to the pulmonary network. The first major hurdle is reversing what we talked about in Section 4, getting rid of the high pressure and the massive volume of fetal lung fluid.
Fluid clearance is a massive, immediate event, achieved primarily in two coordinated ways. First, mechanically. During vaginal birth, the powerful squeeze on the chest expels a significant amount of the fluid from the large airways.
And the rest.
The rest, and this is most of it, is handled rapidly. The fluid that is still in the distal air spaces is quickly and actively absorbed by the capillaries and the newly efficient lymphatics postnatally. Failure to clear this fluid effectively can lead to a condition called transient achipnea of the newborn.
The most immediate and critical physiological event must be the instantaneous reversal of the fetal circulation, dropping that high pulmonary vascular resistance, or PVR.
It is the instantaneous trigger for the entire system reboot. The instant lung inflation occurs, bringing oxygen into those airways for the very first time. There is an abrupt and dramatic reduction in pulmonary vascular resistance. This is the key that unlocks everything else.
What exactly triggers that radical, immediate pressure drop?
The primary trigger is oxygen itself. Oxygen is a potent, natural pulmonary vasodilator.
So it makes the blood vessels relax.
It makes them relax and widen. It acts by inhibiting vasoconstrictive factors that were dominant in the fetal state and stimulating the release of vasodilators like nitric oxide. As the resistance plummets, the blood, which had been shunted away, now rushes into the lungs. This flow increases 10 to 20 times within moments.
And that rush of blood changes the pressure in the heart.
That massive hemodynamic shift dramatically lowers the pressure in the right side of the heart and increases the pressure on the left side, which effectively slams the door shut on the fetal shunts, the foramen ovale, and the ductus arteriosus. This reroutes the entire cardiac output through the lungs for oxygenation.
And the mechanical establishment of independent breathing capacity is achieved through the first few strong, often reflexive efforts.
That's the establishment of functional residual capacity, or FRC. The initial strong breaths and the vigorous crying that follows are essential. They overcome the viscosity of the remaining fluid and establish FRC.
And FRC is the air left over after you breathe out.
It's the residual volume of air needed to keep the airways and saccules open between breaths. It is maintained by the new surfactant and the mechanical integrity of the chest wall. Without FRC, the lungs would collapse back to zero volume after every breath, leading to exhaustion.
So the physiological high resistance is gone, but the physical structure of the pulmonary arteries is still that thick, muscularized fetal structure. They must physically remodel very rapidly to become the thin-walled, lower-pressure adult vessels.
Yes, this rapid physical remodeling process is essential for long-term health and for preventing chronic pulmonary hypertension. The thick muscle layers of the fetal arteries must rapidly thin out into the adult structure. Our sources define this crucial vascular transformation in 3 distinct, rapid stages.
Walk us through that highly constrained timeline of vascular change.
Stage 1 occurs immediately, starting at birth and lasting up to about day 4. This is the period of the most rapid and aggressive decrease in the diameter of the smooth muscle walls of the arteries. The new low-pressure gradient is driving this initial massive change.
And after day 4?
Stage 2 extends from day 4 to roughly 3 or 4 weeks postnatally. This involves a further, more gradual thinning of the muscle walls and continued reorganization of the vessel architecture. And finally, stage 3 is the long-term phase, involving gradual growth, density increase, and the ultimate achievement of the full, thin-walled adult structure throughout childhood.
And failure to successfully complete this rapid vascular transformation has devastating and immediate consequences.
Yes, the failure of this crucial remodeling process leads to persistent pulmonary hypertension of the neonate, PPHN. If the arteries retain that high fetal resistance beyond the first few hours or days, the blood continues to seek the path of least resistance. The fetal shunts, which should be functionally closed, can remain open or even reopen.
Which leads to a crisis.
A dangerous condition where poorly oxygenated blood bypasses the lungs and enters the body's circulation. This is a life-threatening emergency that requires immediate and intensive intervention.
Shifting to the mechanics of the newborn chest, the physical structure of the thorax itself is fundamentally different from an adult's, which has to impact how they breathe and compensate.
The neonatal chest wall is extremely compliant, meaning it is very soft and flexible.
Why is it so soft?
It's due to the structure. The ribs are relatively horizontal rather than angled downward, and they are largely cartilaginous, not yet fully bony. This high compliance means the chest wall doesn't provide the rigid scaffolding necessary to support and maintain lung volume that an adult's rigid cage does.
So how does the neonate compensate for this overly compliant, flexible chest wall? What's the strategy?
They rely overwhelmingly on the powerful and newly operational diaphragm for quiet, resting breathing. Furthermore, because the upper airway musculature is also immature, especially during sleep, neonates often exhibit paradoxical breathing.
Paradoxical breathing,
Yeah.
where the chest moves the wrong way.
Exactly. The compliant chest wall actually sinks inwards slightly on inspiration while the abdomen rises. This is particularly pronounced during REM sleep. They use the diaphragm almost exclusively to generate the necessary negative pressure to inflate the lungs, while the chest wall collapses due to the pressure differential.
Finally, just emphasizing again, the growth is not done at birth. The structural maturation is a childhood event.
Absolutely. The complexity of the lung, the actual number of alveoli, the surface area, and the density of the capillary network increases dramatically postnatally. And not just through inflation, but through active septation and growth. This continuous expansion through childhood, which can last up to age 8 and possibly beyond, requires a clean, protective, and supportive environment to maximize lifelong lung health and function. The architecture built in utero is only the foundation. The finishing work takes years. To synthesize this immense and detailed process, the staggering precision required for the lungs to develop is truly a marvel. From that initial laryngotracheal ridge at 30 days post-fertilization through the 4 stages of refinement to the establishment of that single highly efficient blood gas barrier, every single week dictates the difference between potential viability and guaranteed respiratory failure. The key takeaway for you, the listener, is the lung's unique and extended vulnerability. Its long developmental timeline, which continues for years after the child leaves the womb, makes it exquisitely sensitive not only to early clinical challenges like prematurity, diaphragmatic defects, and vascular remodeling failures, but also to chronic environmental insults.
So the foundations of lifelong respiratory health are not sealed at birth.
Not even close. They are being actively laid down long after, making early childhood protection paramount.
So what does this all mean? Considering that the physical architecture of our respiratory system, the very engine of life that is responsible for fueling every cell in the body, is still actively being built and refined through the addition of alveoli and the expansion of the capillary network up to the age of 8. Well, how might policy changes regarding urban air quality or improved early childhood nutrition fundamentally reshape the maximum respiratory capacity and lifelong health of future generations decades down the line? The embryological timeline of the lungs reminds us that structural growth is not just an embryonic event completed in 9 months, but a constant vulnerable process that demands protection throughout the entire arc of early childhood. Thank you for sharing these detailed sources for this deep dive into the extraordinary blueprint of breath.